SOHO 2023 was another very successful meeting. We have one very large myeloma session. The myeloma session actually is a group of about 8 talks, and some of the talks really, I think, highlighted some of the things I'm very excited about currently in myeloma. And specifically, Ajay Chari gave a discussion about bispecifics and novel targeted immunotherapies, and included some data also on CAR T-cell therapy. It is pretty amazing where we are today, that we have 2 CAR T-cell therapeutics that are approved and now 3 bispecifics that are approved. Now, the majority of these actually do target BCMA, and one of the ones targets GPRC5D. What we don't understand is really how to sequence these therapeutics. For sure, the best data comes from cilta-cel. The cilta-cel in the relapsed and refractory patient population, patients that have received 6 or more prior lines of therapy, although it's approved with 4 or more prior lines of therapy. The initial data is just quite impressive, with a response rate of 98%. And basically patients remaining in remission, a median of about 36 months. That there's nothing that actually meets that bar. So in my mind, that is the optimal therapy for patients who have had 4 or more prior lines of therapy and can tolerate a CAR T-cell therapy and can come to the treatment center and undergo all the logistical issues that are required so that patient can stay at that center for about a month with a caregiver. They can do that. That is my number one. But what is really nice to see, and what we also presented in a real world evaluation of Teclistamab, is that the bispecific T-cell engager for patients who cannot basically either get to the CAR T-cell therapy for whatever reason, or they can't do it because of logistical reasons, that is having, in the clinical trial, 61 response rate. In our real world evaluation, we had 92 patients. Response rate was like 64%. So it's really holding up. The response rate is quite good. 2/3 of the patients are responding to Teclistamab, and patients are getting that relative, I'd say, without much in terms of adverse events and side effects. They do have to come in the hospital. We do it. We administer Teclistamab day 1, day 3, day 5, and then let them go home on day 7. But what we showed in our real world poster is at the Mayo Clinic, where they have a monitoring system, and there's a wearable device that these patients wear. They can treat them as in the outpatient setting, and they treated all their Teclistamab patients. They also treat most of their CAR T-cell patients as an outpatient using a wearable device. And if they have a fever, or if they have, signs that early signs of CRS, with the wearable device, they have a system where a nurse will then call the patient, evaluate them, and find out whether or not that patient is really in distress and should go right to the emergency room, or whether they could take Tylenol at home and fluids, and they'll check in them again the next day. Pretty amazing, actually. I think that's what the future for these are. But Teclistamab, very well tolerated in general. We also broke out a population of just over 10 patients that were older than age 75 up to age 91, and they did just as well. They didn't have any worse adverse events, including CRS or ICANS, et cetera. Now at SOHO, we had a really nice discussion by Dr. Nupur Rajay, who really went over the toxicities of these novel immunotherapies. The toxicities of the novel immunotherapies are generally CRS, which I just mentioned, ICANS, which is really neurologic toxicity. It occurs, I would say, early neurologic toxicity in 3 to 5% of patients, maybe 10% of patients with CAR T-cell therapy. With bispecifics, and what Dr. Rajay said, it's probably pretty low. It's probably less than 2% of patients that actually have ICANS from bispecifics. And we found that in our real world experience too. It's sometimes hard when you're 80 years old and you have a fever at 2 a.m. and somebody's waking you up and then asking you a bunch of questions about who you are, where you are. Can you count back by 100? They don't do so well with that at 2 a.m. I'm not sure I would do that well with that at 2 a.m. And so I think most of the toxicity is really delirium from the fever in the bispecifics, rather than true, effects of cytokines on brain function, et cetera. But the other one that really was highlighted by Dr. Nupur Raji was that infections with the BCMA targeted bispecifics really have to be in the back of your mind for all patients. Patients have risks for bacterial infections, especially after CAR T-cell therapy, when they're neutropenic. They're potentially at risk for fungal infections with CAR T-cell therapy when they're neutropenic. Bacterial and fungal infections are much less common with bispecifics, and we tend not to use prophylaxis with the bispecifics. But viral reactivations are real. So patients are on prophylaxis for VZV. They're also on prophylaxis for PJP. In the initial Teclistamab study, about 5 patients developed pneumocystis. And those drugs have to be given literally in the first year after their initiation of the therapy. We follow CD4 cell counts. If their CD4 cell count remains low at a year, et cetera, we continue those drugs as prophylaxis. And then when patients have a febrile incidence, and so with the bispecifics, we're seeing especially the BCMA bispecifics, we're seeing over time that the infectious risk, especially viral reactivations or viral symptoms, can occur throughout the first year or while they're on therapy, even longer. And you just have to be very cognizant of doing a good workup when somebody has a viral infection and treating them as you would for somebody that's immunocompromised. Dr. Chari at SOHO also talked about Ciltacabtagene. Ciltacabtagene is one of his, I call it his drugs because he's probably treated the most patients on that medication. And that the infectious risk might be a little lower at Ciltacabtagene. That patients may not develop as severe hypogammaglobulinemia after Ciltacabtagene. And therefore, may not have as much in terms of viral reactivations, but you still have to do a broad workup with Ciltacabtagene. I will say that everybody on the panel and everybody that we discussed this with said that those patients who are receiving bispecifics, especially BCMA bispecifics and CARs too, they almost uniformly develop hypogammaglobulinemia. And we have been giving IVIG, intravenous gamma globulin, as supportive care, again, throughout their therapy or until they can maintain their own IgG level of greater than 400. This is very important. We actually start at UCSF, we start in cycle 1 on either day 15 or day 22, whatever works out most convenient for the schedule, for our schedule, the patient schedule. That's when they get their first dose of IVIG. We had another poster at SOHO from UCSF looking at infections in Teclistamab. And basically what we said is about 30% of patients were hypogammaglobulinemia before they even started Teclistamab therapy. So all the prior therapies that they had, they're mostly triple class refractory. A fair number of them actually had prior belantamab methadone. They were already hypogammaglobulinemic. So again, we start in the first cycle, we start giving them IVIG, and they continue that to maintain their IgG levels greater than 400. I think that's really important. In our infectious poster, we also showed that CMV reactivation was common. And we also discussed this in a group too, in the group setting, but that it was very rare for us to see CMV disease. So we didn't actually treat any of the CMV reactivation. We just followed it. And in fact, in our experience, the IVIG seems to mitigate the CMV reactivation. And you can then see the CMV titers start to go down, which is really nice, actually. So you don't have to give them ganciclovir unless you think they have organ disease, or you think that their fevers that they're having are from CMV. If it's just CMV reactivation, IVIG should be enough. And in fact, I like to spare them ganciclovir so they don't have subsequent neutropenia from blood count suppression from the ganciclovir.